Good morning or afternoon, depending upon where you're joining us from. I am Ann Greiner, President and CEO of the Primary Care Collaborative, and I want to welcome you to today's webinar, Integrated Primary Care in Medicaid and CHIP. For those of you who may not know the Primary Care Collaborative, we are a national organization that convenes and unites diverse stakeholders around research, primary care delivery models, and policies that strengthen comprehensive team-based care. We host monthly webinars that are free of charge to the primary care community. All of our webinars are available on our website for download, and that website is thepcc.org. Next month's webinar, and we'll be getting information out about that shortly, will focus on primary care and AI. Today's event, so we're focused on how can we better integrate behavioral health and primary care and Medicaid. We certainly know that we have a national crisis when it comes to mental health issues and substance use disorder, and that we need across all payers to better integrate, but today's focus will be on Medicaid. I want to thank the California Healthcare Foundation for the support that they've provided to the Primary Care Collaborative in developing our work in this area over the last year. A report that was published in August, and then that looked at delivery and payment innovations in Medicaid and the evidence behind them, as well as the policy work to focus on what we will advance in this space in the coming years. Now let me turn the dais over to Stephanie Glier. She's Director of Federal Policy at the American Academy of Pediatrics. But before I do, a couple of housekeeping items. All of your lines are automatically muted. We will take questions from the audience in the last 10 minutes, but don't wait till then. Put them in as they occur to you so we can get them all in the queue. We also will make this webinar available within 24 hours, along with the slides and other materials that the PCC and our speakers have identified. Let me now introduce you to Stephanie. As I said, she's Director of Federal Advocacy at AAP. And there she is focused on promoting children's health coverage, access, and quality. Previously, she led the Consumer Purchaser Alliance, a coalition of consumer, employer, and labor organizations that were all collaborating to improve the healthcare system. Stephanie has also worked for HHS, CMMI, and the Commonwealth Fund. Delighted to have you here, Stephanie, and over to you.
Thanks, Ann. I'm sorry to jump the gun. As you heard, I have a lot of experience working in diverse coalitions like this one, and have been thrilled to be able to continue working with PCC. Let's go to the next slide. In addition to PCC, I wanted to share a little bit about what PCC has been leading with the Better Health Now campaign. So for those of you who are not yet familiar with the campaign, this is a campaign organized by PCC that brings together another set of diverse organizations with a united goal. And that is a high-value, lower-cost, equitable healthcare system that prioritizes whole-person primary care. Better Health Now is more than 50 organizations strong, representing patients, clinicians, employers, health plans, researchers, health systems, tech firms, pharmaceutical companies, really, truly a very diverse group. And these groups really share the common belief that communities across the United States deserve to be healthier, and that primary care is a big part of the way that we get there. Let's go on to the next slide. I have been really thrilled to be working with the Better Health Now campaign to focus a little bit on Medicaid. We are talking today, the Better Health Now campaign has been talking about two federally focused priorities for Medicaid, and we're talking about a big one of them later today with this panel. The reason to focus on Medicaid, right, is that it is a huge and important program. Nearly 90 million people across the country and across the lifespan are enrolled in Medicaid, including 1 in 5 Medicare beneficiaries and nearly half of all children. Because the program is a state-federal partnership, there is less uniformity than we see in Medicare, and that means that states have a lot of opportunity to innovate. But we also know that the federal government needs to take the lead to both permit and promote the innovation happening at the state level to best support enrollees' health. So we are calling on federal policymakers to support state Medicaid and CHIP programs to offer well-designed population-based payment models that include enhanced investment in primary care and strong alignment of payment and measurement approaches across payers, and to promote and equip primary care to integrate whole person health, especially integrated behavioral health care. I do want to pause and recognize that that phrase, integrated behavioral health care, encompasses quite a lot of services and types of care. And I also note that it can be an alienating phrase to some communities. The Better Health Now campaign is using the phrase to mean a whole spectrum of services that can support mental, emotional, and behavioral health and can include substance use treatment. I know our panel will be able to talk more about that a little bit later today. Let's go to the next slide. This one just shows you the set of recommendations that Better Health Now has made for how CMS could further promote the goals that we've unified around. I would recommend that you go ahead and read through the one-pager that the campaign has put together to get a better sense of what we are recommending. And in order not to take too much time here to talk about that campaign, I really want to make sure that folks have enough time to hear from our expert panel. I would love to turn it over to our moderator, Kathryn Phillips.
Thank you, Stephanie, and good day, everyone. My name is Kathryn Phillips. I'm an Associate Director at the California Healthcare Foundation and I'm pleased to be a sponsor of the Better Health Now campaign and just delighted to moderate the session today. As Anne and Stephanie noted, we have 3 panelists, all experts and devoted champions. Marian Earls is a general and developmental behavioral pediatrician whose career is focused on Medicaid policy, practice transformation, and the integration of mental health into pediatric practice. She currently chairs the American Academy of Pediatrics Council on Healthy Mental and Emotional Development. We also have Sara Rosenbaum, who's a professor emerita of health law and policy and founding chair of the Department of Health Policy at the Milken Institute at George Washington University. She's devoted her career to issues of health justice and is well known for her work on health reform, Medicaid, health insurance, and managed care, as well as healthcare access, just about all of the important topics. And last but not least, we'll be joined by Naomi Fener, who is a director of population health for Families USA, where she drives policy change around population health outcomes and the social drivers of health. She's a nurse practitioner by training, and she has clinical and policy experience with under-resourced community, including working for Massachusetts Medicaid agency. So we are going to begin with questions for each of our panelists, and then we will open up for the audience. So please begin thinking about questions you have for the team now. You're welcome to enter them in at any time. And again, we'll address those at the end of our session today. First, I'd like to begin by welcoming the panelists to turn on their cameras and join the conversation, and really to start with what draws each of you to this topic, the lens you specifically bring to the need for integrated primary care. And Marian, I'll ask you to go first.
Sure. Sure. So my lens, of course, is from a pediatrician's point of view, but specifically from the perspective of the AAP mental health competencies for pediatric practice that we really delineated back in 2019. And they really include things that are clinical skills, right? So, and we really identified that mental health starts with promotion and primary prevention, goes through secondary prevention, early identification, assessment, and treatment, and with a focus on people co-managing and collaborating. And so for kids who do need services, that there's a warm handoff possible for that. And then there's the practice enhancements piece. And, you know, that really talks about systems change in practices and collaborative and consultative relationships. My other lens quickly, since you mentioned it already, is that I'm the chair of the new council from the AAP on healthy mental and emotional development. They formed the council in 2022 to respond to the declaration of a national emergency related to pediatric mental health, and wanted the council to be formed as a strategic focus to address the mental health needs of infants, children, and adolescents. And the role of the council is really to advise the AAP board to move where to move. And our focus is on moving policy to action. We'll be talking about that today, right? Strategies to do that implementation, to spread innovation, and to promote needed systems change. So that's my lens, and I'm very interested in practice transformation, but I recognize that in order to do that, we need policies and procedures and payment, et cetera, to facilitate that. So probably more than you wanted to know, but.
Terrific, thank you, and appreciate you weaving in the importance of prevention. Naomi, what about you?
Thank you. So I think for me, again, I am a nurse practitioner, so I do come with that perspective and really seeing the detriment that my patients have from not being able to access care, having trouble accessing behavioral health care. And then in my role at Families USA, we are really moving our focus from just healthcare to health. And a lot of what you highlighted in the Better Health Now campaign, we're starting to work towards as well. And enhancing primary care and mental health supports are a huge part of that. And one of the things that we also want to focus is leveraging these enhanced supports and to center health equity and make sure that everyone has access to these supports, not just certain parts of our population. And one of our partners, California Pan-Ethnic Health Network, runs a behavioral health equity collaborative that has done a lot of really great work in that space. And then on a more personal level, like I, again, as a nurse practitioner post-COVID, had been in a COVID ICU, caring for patients and really struggled with my mental health. And even working with my primary care provider, it took me 6 months to find a therapist that was accepting patients. And that's someone who's educated, who knows the system, had really good health insurance. And the only thing my primary care could offer me was send emails to therapists and just keep sending them. And it was just like, I feel like you should be able to do more. So it's a personal thing for me too, to make sure that folks have access.
Thank you. And Sara? Oh, I think you're on mute.
My tie to this subject goes back to my involvement in one of the nation's first EPSDT lawsuits about 50 years ago, when I was a tot and Medicaid was young. And I continued my child health work, both in legal services and then at the Children's Defense Fund, and of course was deeply involved in the 1989 revision to EPSDT that greatly broadened the scope of benefits to which children are entitled as a basic requirement of all Medicaid programs. And we did that precisely because mental health coverage was so deficient in so many states. So mental health and mental health care was a driver of the 1989 amendments. And at the same time, through the 1980s, I did a lot of work on what we know today as managed care. Actually, I started my work on managed care back when I was in California in the 70s, and of great interest to me over the course of my academic career, my career as a researcher after I stopped being an actively practicing lawyer, has been the convergence of managed care and coverage and networks and access and the integration into these large contractual arrangements. So
thank you. And that's a perfect segue into our next question. Stephanie noted the critical importance of the Medicaid program for all people with low income, but specifically America's children. The program has grown and changed over time. And one of the big changes has been the introduction of Medicaid managed care. So today, 80% of children with Medicaid are enrolled in a Medicaid managed care plan, and the percentage of adults is increasing as well. So I'm curious, Sara, for your input, how well is Medicaid managed care accommodating integration? And what more do you think Medicaid managed care can do to assure their members have access to integrated care that really meets the needs of their family?
Well, of course, the answer varies greatly depending on the state. Some states have made this issue a high priority. I tend to think about this in two buckets. The probably more complicated bucket is those states, and I don't have a list of them in front of me, that continue to have separate contracts for physical health care and what they call behavioral health care. And going back to my earliest work studying Medicaid managed care, including research supported by SAMHSA, I reached the conclusion that the worst possible situation to find oneself in if you cared about integration was to separate the two. It's just, and it's not the fault of the plans. It's not the fault of the states. It's not anybody's fault. It's not the fault of the providers. It's just the nature of trying to pull apart networks and protocols and handoffs and integration and all of the things that become such a central issue in improving mental health and addiction services when you're dealing with two entirely different companies. And so what states and plans have to deal with, not just two companies, right? I mean, most states have multiple Medicaid managed care organizations, and they may have one behavioral health organization covering the state, but it's having to deal with multiple contractors. So managed care is an extremely difficult thing to do anyway, and probably even more so when across two different forms of insurance, people are having to negotiate where coverage starts and stops, who gets to decide certain critical issues in access and treatment, who gets to deal with treatment plans, whose responsibility it is to achieve care integration, how do you do warm handoffs between two entirely different networks. Certainly, there's a fair amount of mental health care now that happens in primary care settings. But oftentimes trying to articulate for your general purpose company and your specialty companies where the line gets drawn and what belongs in primary care and in the general plan and what's a specialty service can be very difficult. And I think that that ends up adding an additional level of complexity to what is already very complicated. When it's one plan, you still have all of the problems of integration and handoffs and who does what and everything else, but you don't also have multiple corporations. I'm not sure, it's been a long time since I've studied what is often referred to as behavioral health plans as a separate and distinct part of Medicaid managed care. But I can't imagine it's gotten any easier and that the challenges have shrunk away.
Thank you. So Marian, you're a provider. What's your take? And if you could wave your magic wand in Medicaid managed care to improve integration, what would you do?
Right. Well, I think, Sara, I'm like over here clapping for things that you were talking about. But, as a provider, I want to make the distinction about when we use the term integration, what exactly we mean, right? So in primary care, integration can mean that the primary care practice integrates mental health competencies in the way that they do things, which means they're going to do screening, they're going to do early identification, they may do treatment, right? So we need our Medicaid managed care plans to support all of that. And I'll tell you, in my work with states on practice transformation from state to state, some people can't even get that done in their practice and get paid for it. But then there's integration that has a more precise definition, which is used to describe a specific modality when there's a mental health clinician who practices in the primary care setting as a member of the medical home team, not somebody co-located, somebody integrated, seeing patients as practices see them. So I spend a lot of time talking to states about their Medicaid managed care plans and and what are the things that facilitate this. And to Sara's point, the thing that absolutely is the biggest barrier that I hear about from providers are carve-out systems of mental health. The American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry have been clear that carve-out systems of mental health for children is bad for children. And that's been for a number of years. And for all the reasons you're describing, in terms of being able to do a warm handoff, to even identify if there's somebody qualified to see a very young child, or somebody, you know, who can see a 10-year-old with depression, but the only people on their credentialed in their system sees people over 15 or 20. So those sorts of things make it very difficult for somebody to be in medical home and do this work. You probably are aware, in August of 2022, CMS put out an informational bulletin that I was clapping my hands for, and hoping that many states would implement these things. So there's a combination of things that they could do to facilitate at the practice level and then at the plan and system level, right? So they need to increase their payment rates to give adequate network, right? To your point, Naomi, you were saying people can't even find somebody to see kids. They need to eliminate administrative barriers for providers who want to credential under several across managed care plans so that the access and availability is there. They need to eliminate prior authorization. They need to not require a mental health diagnosis. So in some places, if I have a child who's having really significant functional problems but doesn't have a DSM-5 diagnosis, a mental health professional can't see them and bill for it. And so, you know, that needs to change. And there needs to be that ability to use a non-specific code and not a DSM-5, right? Recognizing the promotion prevention piece of all of this. Utilizing things like the DC 0 to 5 for young children, that's more appropriate. You know, lots of things like that. Supporting integrated care, supporting payment models. You have to allow for same-day billing if I have an integrated person in my practice, right? And you need to support that mental health screens can be done. There are some places where people can't be paid for doing a mental health screen as part of primary care. So there's so many pieces there that could make a difference. And then of course there's other things like, you know, support for the child psychiatry access programs and those sorts of things, which goes beyond managed care, obviously, just itself. But I think there's so many things that Medicaid programs can do. If you think about the parity piece and access to care, right? So mental health professionals in Medicare get paid better by Medicare than they do by Medicaid. So there's not an incentive for mental health professionals to see kids, and particularly to see very young kids. So my list is long, as you can hear, but I think all of those things are really, really important in order to make this work. Having parity between Medicare and Medicaid is a very big one, as if pediatricians and family medicine and other primary care clinicians aren't seeing kids who have a lot of complex needs and need to have the payment for that. So yeah, I could go on, but I think those are my top facilitators and barriers and what Medicaid could really do to make this possible for children and families to get access.
Yeah, and a good reminder, both payment rates and administrative burden are key for access.
Mm-hmm.
All right, so we know that mental health and addiction care are essential for all people. Mental health is of particular importance to our nation's youth. Marian, I'd like you to speak to some of the unique needs of children, of adolescents, and of families, and what you think Medicaid should do differently to address these needs as we think about integrated care. What's really different with kids from adults on this topic?
Yeah, I think we sort of touched on it a little bit with the last question, but if you think about the spectrum of what somebody sees in primary care with children, right? So, sometimes, 10-15% of kids might have, their parents may come in and say they have a functioning, problems with functioning. Maybe they're getting in trouble in school or in childcare, or there's functional issues at home. They don't have a diagnosis, right? And so that's a lot of the kids we see, right? And we're being asked to screen kids of all ages around their social emotional development. So the need there is very big, and usually mental health systems focus on people who have more intense needs. And even there's the kids who have parents have concerns. So the value for me in my integrated care practice was to have a mental health person who could talk to families about parenting and issues at home without having to have a diagnosis. And then, of course, 20% of kids actually do have a mental health diagnosis. And then the issue is, can I find folks that see that age group and take care of that age group? And can I collaborate with them? So I think those kinds of things are what's unique about pediatrics. People leap with the crisis to, I need psychopharm. And yes, people need to understand about psychopharmacology, but there's so much more in pediatrics that we do. And there's not really support for services, for prevention or services to kids who have emerging or mild to moderate conditions. And then, of course, finding people who serve kids is pretty difficult. The other piece of pediatrics is you don't get just the child, you get the infant, the child, or the adolescent, you get the parent, you get the family, you get the caregiver.
Plus family.
And so, now there's this big interest in relational health. And if we're really going to serve that child, we also have to be able to assist with that, with what the family needs. So for instance, we now can, Medicaid suggested in 2015 that we should be screening moms for caretakers for perinatal depression screening in practice, and we should be helping support that. And they made it possible. They gave the code out to the states. They allowed states to pay for dyadic therapy, with a young child and the caregiver. Those things aren't universal right now. So
improvement there.
We really need.
And Naomi, you're a family advocate. What comes to mind for you on this issue of how best to support families?
Yeah, I think Marian's brought up some really great points. I think one of the things that we think about a lot when it comes to children in the family unit, however that family may look, is really meeting them where they are. And for a lot of these folks, schools is a really positive place, ideally for a lot of these children. They're in school a majority of the day. A lot of children identify having either teachers or counselors or someone at the school that they trust, and that can be a really interesting and positive entry point into the healthcare system. So, ideally, one of a few things that we're looking at is not just integrating behavioral and mental health into primary care, but also into the schools and being able to, as we talk about, ways to improve that. There are some really great programs that a lot of states are leveraging. And so getting more states to leverage the health services initiative, that's super underutilized, and that's using some CHIP admin dollars for some of these services for any low-income child, not just those enrolled in Medicaid and CHIP, which is a really great, I think we have about 14 states that utilize a state plan amendment that allows Medicaid to pay for health services that are delivered in the school. for anyone who's on Medicaid, not just those who have IEPs, which is also really important. And then have to give a shout out to my old colleagues over at Mass Health, who have done some really innovative stuff through their 1115 waiver, through their primary care subcap program, with a lot of integrating behavioral health, and with schools. Their kind of highest tier of primary care requires that they have a staff member within that primary care practice that is dedicated to working with the schools, which is really great to have that direct connection between the practice and the school. And then also what's really great, CMS just announced yesterday, $50 million in grants for states for critical school-based health services for children. So there's a lot of really great opportunities already, and then also like really thinking through what sort of alternative payment models we can leverage in the future to try to help with integration between the schools and the practices and kids.
Thank you. And Sara mentioned earlier some of the challenges within Medicaid managed care relevant to integration: multiple plans, multiple contracts, siloization, fragmentation, pay parity. I'd like to invite you to that conversation to think about the biggest challenges to achieving integrated whole person care, not thinking just about plans or the mechanics, but the actual work of integrating primary care and behavioral health for the Medicaid population. What comes to mind for you as you think about challenges regarding workforce, et cetera?
Yeah, I think one of the biggest things is definitely workforce. Marian already alluded to this, is the pay parity between Medicaid and Medicare. And I think, you know, there's a real issue with our workforce right now, especially seeing Medicaid patients, and we can't have true integration until we have a strong workforce to support it. And so we really need to shore that up, both with the pay parity. Marian also mentioned reducing administrative burden on those providers, which is really important. And then also just really creating a more diverse workforce, and making sure that we have representation for folks so that they feel more comfortable when they're doing that. And so what's been really interesting, CMS in New York's 1115 approval that I think was approved a couple weeks ago, they're giving funding towards, or earmarking funding towards, increasing Medicaid rates to at least 80% of Medicare rates, which is for primary care, behavioral health, and I think OB in labor and delivery, which is really great to see that, you know, CMS is pushing on this too. I would say 80% isn't quite enough, but you know, it's a starting point. And so we can at least start there and keep moving. And then a lot of the waivers that we're seeing also have money towards workforce recruitment and retention, which I think is really great. And really starting that recruitment when folks are younger, not necessarily offering, you know, loans or loan forgiveness after school, but talking to folks when they're deciding what to do with their life in like middle school, high school. Super interesting stuff they're doing there.
So earlier interventions, I'm assuming around tuition subsidies or, okay.
Yeah.
All right. Sara, back to challenges. What else would you put out there on the topic of integration?
I can't think of any other issues that we haven't flagged. What I would say is the challenge of building a strategic framework. And what by that I mean, I am not sure, for example, when advocacy is happening at the state level, say around managed care and how managed care is performing, and what can be done to strengthen managed care. The most important step is to translate those aspirations into actual contract language. And I am not aware of anyone who has attempted. We've done this. I've done this at GW during my career, but I don't know of any systematic effort to develop tools for advocates and for states around developing proper contract language, both for situations where you have a single unified contractor, as well as situations where you are dealing with multiple contractors, on everything from how integration what the expectations of the plans are, and of plans are on coverage, access, networks, and what the expectations are on how handoffs will work, how treatment plans will be developed. I mean, it's the whole Megillah, okay? And that is, I think, a like a Manhattan Project to do the kind of review of the current state of managed care contracts around pediatric mental physical care integration, and then bring a group together to really develop the actual language that you would need. And it becomes, when I've done this work, it becomes a great tool for states. I mean, because states often don't really know. Some states are, sort of quite fantastic in how much they have in-house expertise to be able to tackle these very difficult issues, whether it's for children or for adults. But a lot of states don't. And so it ends up being a way to be able to say to a state and to plans themselves, and because they negotiate these arrangements, what we need to be clear in our expectations. What do you want? How should this work? How do you balance, particularly the need for clearer direction against not so tying everybody's hands with micromanagement that you don't have any room for innovation across this, complicated issue. And so it's a really meaningful project in the sense that it would force everybody to stop getting beyond the general statements of this is how the health system should work, and get into the reality of what do you want to buy? What really do you want to buy?
And it's a great reminder, contracting is a powerful tool both to set expectations and to enforce those expectations.
Absolutely.
And building on Naomi's part, author, a guide of where you need to invest, whether that's workforce or access point or others.
Right. Right.
All right, so we're on to our last panelist question here. Just a reminder to the audience, please begin putting your questions in and we'll turn to those in just a moment. I wanted to ask Naomi to begin on the next one, which is ending on the high note. What brings you hope about this work? And knowing that Better Health Now is a campaign, a collective of champions, what one thing could audience members do to support or further change in this area? What would you ask them?
I mean, I think that Families is very supportive of Better Health Now campaign. We've signed on to it. I love that folks are talking about it. And I would say, like, whatever your role is within the healthcare system, whatever you're bringing to the table, make sure that you're talking about this, researching it, and like talking to legislators or kind of whatever voice you have, making sure that you're using it when it comes to things like this. The more that we can have those conversations and bring issues like this to light, I think the more that we're going to be able to do around it. I would say, like, even when I was in nursing school, like 10-ish years ago, no one was talking about this integration. No one was taking the perspective of the patient when it came to how does it feel to go to your provider and not have anywhere else to go. And so it really gives me a lot of hope that we're having these conversations, and I think just continuing to have them and bringing them to the forefront and just keep pushing on it would be super helpful.
Okay. And Marian, anything come to mind for you? What would you ask other champions to do to help you and your work?
I think the thing that gives me hope is similar to what Naomi is saying. Right now, this is front of mind. Everybody wants to talk about this. Everybody's heard about the crises in this country, the way that children and families are really suffering with all of this. I think my hope is in the advocacy work that's happening. I'll put in a big plug for the AAP, and that, in October, they came out with a statement on Medicaid and CHIP, that Medicaid and CHIP should be standardized across states, that it should be better funded. Lots of the things that we mentioned already in this talk, but I think that that's very exciting that that's getting that national attention. And then, you know, I don't know that it was in our resources, but the child and adolescent mental health principles that have come out. AAP is one of I think it's 31 organizations that have come out with these principles that address a lot of the things that we're talking about: prevention and promotion and early identification, school-based mental health, which was absolutely brilliant that Naomi brought up that topic. Integration, how do you support integration? How do you really make it possible for primary care folks to have an integrated mental health person? What are the payment structures that support that? Workforce, it has recommendations around workforce development, payment, parity, if you're interested in telehealth, crisis services, and then justice-involved youth. I think that for people who are listening to this, that's a really good place to start in terms of the principles. That was the latest version of this is from April of 2023 with all of these organizations. And I think I think advocacy is what gives us hope in doing this work. So that would be my recommendation, that people choose something that they want to have part of their own personal advocacy about this.
Thank you. All right, well, let's switch now to audience questions. Can the panel comment on the role of allied health professionals, community health workers, peer specialists, or peer supports in addressing the workforce shortage and access care concerns, specifically for youth behavioral health? Who'd like to take that one?
Oh, I would just note, I mean, it's something that I know has received a considerable amount of attention, especially peer support. And I think the issue is whether, you know, it's again the same thing, whether these whether the broad goals of enriching who provides care because of the unique skills of certain kinds of, as you call them, allied professionals, whether that care is possible in a given state. What's the scope of practice laws? What are Medicaid and CHIP payment rules? You know, what do health plans pay for these services? I do a lot of work around community health centers, going back to, again, the beginning of my career. And of course, in many, many states, the federally qualified health centers payment mechanism is should be enveloping all of these services because of the emphasis on allied professionals and ambulatory, rich ambulatory care. And often what you find is that the rates are not being updated properly to reflect new kinds of practice, much less inflation. And another problem that I think people are not aware of, which is a serious problem, is that you can have nominally a very good FQHC payment rate that reflects pretty broad scope of practice and, you know, allowable costs. Managed care plans often withhold a substantial part of the payment they make, and it sort of defeats the whole purpose of the PPS, which was to do a prospective payment. So they withhold a big chunk of the payment and make an interim payment that is no greater than the fee-for-service rates they're paying, and then put the health centers through cost settlements, which is ridiculous. They don't have to do cost settlements. This is the PPS rate. I have questioned this for years, why CMS allows this. It means that even when you have a good rate that reflects the right kind of practice, your revenue flow is problematic. So there are all of the problems that have been flagged around what I'll call office-based practice. And then there are these unique problems that arise in the context of community health centers, which are, you know, they're at this point in so many states, they are the backbone of the whole system. They and pediatricians are you know, just the front line of everything.
Okay. So the next question is on communication. And Marian, you noted that integration isn't just about payment, isn't just about contracting, but is the way providers, caregivers, families, and teams work together to deliver care. Integrated communication is key, says this attendee member. How do you see communication improving? What needs to happen from current state to really live into fully collaborative care?
That's a great, it's a great point. Our systems don't necessarily facilitate that happening, right? So for 18 years in my practice, we had integrated mental health professionals. So I can speak to the benefit of that ability to have that communication, right? So if someone's integrated in your practice, you have a shared chart, you have communication, you're seeing patients together. If you're working with people in the community, whether that's a licensed clinician or it's a psychiatrist or a psychologist, to be able to have that communication is really key. And we don't have systems. In fact, what we do is we put up confidentiality walls and we don't communicate well. And I was in a meeting once where a family member raised their hand and said, it's indicative of our system that people have to have a care coordinator because nobody really communicates effectively. So I think that really intentionally looking at systems at the way we communicate is exceedingly important. It's very effective. And what we found with the ability of having an integrated mental health person who could communicate with that community person if we were making a referral made a huge difference because it was a warm handoff. The communication went better and families were more satisfied with the fact that we were collaborating. And obviously the family is always part of that collaboration. So I think it sounds simple, but it is so needed. And if you listen to families who feel like they get referred here and they get referred there and people aren't talking to each other, it's really significantly difficult. And with mental health issues, for the folks that are taking care of those children and families, to have those collaborative relationships and those consultative relationships is really important. HIPAA actually allows communication, by the way, even though people don't understand that. Now there's the child psychiatry access programs that have not only psychiatrists, but clinicians for people to be able to consult. And there's also a proposal for payment for someone consulting with another person and having that consultative relationship and both being able to bill. So I think there are facilitators for that, and I just think it's absolutely key with all of this.
Okay, great. We've had a couple. Oh, yeah, go ahead, Naomi.
Please jump in. Marian touched on. I think one of the other things that we could do to help with this too is have some best practices around, as Marian mentioned, HIPAA, and then also the FERPA, the Family Education Rights and Privacy Act, and that governs a lot with like school-based and just how can we communicate while also respecting privacy and making sure that communication. So I think there's a lot of misunderstanding in how to do that while following the rules and making sure that there are best practices.
And if the family is always part of the exchange of information and the release, it's funny how that works. If we did a better job of engaging the family in that process.
So we've had a couple questions come in on examples and evidence of success. Are there any examples of states, systems, or communities that are doing it right? Ones you would recommend readers look at, think about, learn from. Improved outcomes, cost savings, family engagement, you name it. But examples of those on the right track that we can learn from.
I think there are some really interesting, especially when you're talking about alternative payment models. I think it's too early to really say that some are successful or not successful. And I think how we define success is really important. For a lot of these programs, I don't think that we will be necessarily having a short-term return on investment, especially when you're talking about kids. But in the long term, I think we definitely see that there is a practice in Western Mass that has a school-based care coordinator that is funded because of alternative payment models, funded 50% through the school and 50% through the practice, because they've seen such positive ROIs having that really good integration. But I'm super excited to see, especially this most recent set of 1115 waivers, to see what comes out of that. Really excited to see what happens with the subcap system in Massachusetts, and them really pushing integration in primary care. I'll try to do some more thinking.
I think looking for a state that's doing all of the above, that's probably not what we're going to be. I will say in my own state of North Carolina, the Medicaid program has really actively supported integrated in primary care since the early 2000s. And so there were a lot of pediatric practices that have an integrated person. When we went to managed care for mental health, that really threatened that integration, but there's been work done for that. The states that have done extremely well with their child psychiatry access programs and the consultation, I can think of Massachusetts, which is one of the earliest. The state of Washington has done amazing connection with primary care. And, when you think about you're trying to expand access and expand capacity, it is a way to expand capacity. Virginia has done really amazing things in their early years of that work. So I think that there are places that are doing pieces of this, either fostering the facilitating integration of someone in practice, but also people doing things like parity. We just got parity. We have 100% Medicaid to Medicare in North Carolina, and other states that are trying to move in that direction. There are some states that are doing parity between mental health payment between Medicare and Medicaid. So I think those are the things to look for. We almost need a sort of a compendium of all of those things for all the states to really know about that, and maybe expand innovation if people do some really innovative things with their waivers, to expand that to other states to be able to do that. But anyways, that didn't answer your question, but I do think that there are places that are doing some really trying to do some really creative things.
Lots to learn and leverage. Not one state doing it all, but many bright spots. All right, Sara, I'm going to ask you to take the next question, which is, how can Medicaid managed care contracts or policies better advance health equity, especially in the context of integrated care?
Well, I would say they advance health equity by getting cleared purchasing specifications that have been developed over time with a lot of input from health professionals, advocates, and the plans themselves about what we want. What should the delivery and coverage system look like? What should its capabilities be? How should it be performing? And how do we translate that into contract specifications? And how do we do that without essentially being overbearing on the specifications? That is the great challenge that all states face, that all plans face. How do we get performance that we're supposed to get? How do we have enough information to know how to, what's expected of us? And how do we ensure enough discretion so we can try new things? But there's no easy answer to this. There's no aspirational pathway to this one. It is very, very hard, detailed, grinding work with experts in the field, both from the payer side and the provider side, about how you want an integrated system to work and function, and then setting up not just the sort of end game performance measures, which are always sort of so broad, it's very hard to get anything meaningful. A lot of what I'm talking about here are intermediate measures. They really are intermediate measures, and states, when we do our managed care contracting work, there are a lot of states that do really incredible work on various aspects of managed care. Typically, no one state does everything exactly right, but in the areas that I've tackled over the years, I say the work I did in mental health, behavioral health is too old now. It goes way back, but in more recent times, you can see contract excerpts, and you can see that states vary, and they're strong, or they're on certain areas and more limited in others, but you can look to see what they've tackled. It's just to pull an example from maternity care. If you tell the plan in the contract that prenatal care is covered, once upon a time, it was okay maybe to say that, of course, prenatal care is covered, but to provide no expectations for what that prenatal care ought to encompass, what the network elements are, what the access expectations are, what the performance expectations are, et cetera, et cetera. Just what is pregnancy care at this point is a huge issue. And so you have to sort of tackle child health in the same way.
Thank you. All right, we have one last question, and then we'll move to close out. We've spent a lot of our time focused on the needs of children and youth. We had a couple questions come in around adults, and one specific on adults engaged in the criminal justice system, how they can receive better integrated care, and what Medicaid programs specifically can do to help connect them to integrated care. Naomi, may I ask you to start with that?
I was going to say, there's the new CMS initiative in this area. I mean, both as a demonstration, and there are new state options for children. I mean, state requirements for children. So, and that's obviously the aim of it. Naomi, I'm sure you guys are working on this.
Yeah. So I believe California has this approved. And I don't know if anyone else has been approved. Maybe New York.
I think there were a few pending, but only California was approved at this point.
But yeah, so I think it's the Medicaid reentry program.
Reentry demonstration. Yeah.
Yep. And so I think that what is super exciting about it is that depending on what states ask for through their 1115 waiver, it's either 30 or 60 or 90 days before they leave incarceration, they're able to access Medicaid benefits, and that kind of gives them a leg up as they're leaving. And for folks who aren't as aware, when you are in the justice system, you lose your Medicaid benefits. And there's a separate healthcare system for folks who are justice involved. And there's a lot of issues with access within that system. And so the sooner that we can, and a lot of access and integration issues related to integration of that system back into Medicaid or whatever system they're entering into. And so having that period to allow folks to start seeing providers and get connected to services is really helpful. And so I think starting there is really wonderful. And a lot of states, there's federal guidance on it now. So more states should be requesting it through their 1115, and hopefully we could, codify it and have it federally.
Okay. Thank you. All right. Any final closing thoughts, key points any of you wanted to make that we didn't get a chance to address? No. All right. Well, an excellent conversation. Thank you to the audience for our questions. I see already some links that have been provided for more information about some of the examples that were lifted up. I want to thank Stephanie for previewing and walking us through the Better Health Now campaign and policy statement, and to our panelists, Marian, Sara, and Naomi, for their thoughts and reflections today. We covered a lot of ground. As noted at the beginning, you'll receive a copy of the deck and also the recording. They will be posted on PCC's website, which is thepcc.org, within the next day. Again, thank you all for joining and for your interest and commitment on this important topic.
Thank
Have
you.
a good day.